getting here, I have about 50 slides, but I will just rush through it. So maybe we'll save some time for question and answer. So my brief today is on the social and economic implications of the COVID pandemic. Well, actually, this was a version that I was delivered last month to a high-level meeting of people from all over Asia. They were taking the deep dive. They call it a deep dive session on COVID, which is basically an update from the people working in COVID, including our Dean of Public Health, Y. Teo, and then we also had the Director of Medical Services, and then followed by a visiting professor, Tiki Pang, and myself, to speak on, for me to speak on the implications of the COVID. Well, as you know, it has been going on for about 2 years now, and WHO has hinted that the emerging infectious diseases was going to be at the rate of at least 1 per year. Because the viruses are becoming more and more numerous and the mutations are becoming more numerous. So as you can see, the last big one that affected us was SARS, and this is basically a variation of SARS almost 15 years later. And before that, we had all those major killers like Ebola and so on happening in other parts of the world. But now, because of the technology and the speed of travel, what took place, say, when things was much slower and took place over 1 or 2 years now is all compressed in a few days. So one end of the globe, when you have an epidemic or local outbreak, can potentially reach other parts of the earth as well. So thus creating a pandemic, a worldwide pandemic. So whether it is COVID now or SARS in the past or some variation of flu, the other emerging infectious diseases is basically a time bomb, endemic time bomb. So in the year 2005, basically, I presented a paper to give the Asian perspective at a very major conference in Korea, when we hosted the Trilateral Commission that was headed by David Rockefeller. And the Trilateral Commission, of course, as you know, is a multilateral one involving all the diplomats and all the big captains of industry, plus the government leaders are all involved. No? So I presented a paper, and later that I know that we were almost predicting that it's going to be a global pandemic. And so those papers that were presented in the year 2015 were then turned into a book that was edited by the then Dean of Public Health, Julio Frank of the Harvard School of Public Health. So I had a chapter there, basically giving the Asian perspective that we may face a worldwide pandemic. And that was about 5 or 6 years ago. So as you can see now, we were just harping on the possibility that perhaps we need to securitize this pandemic or public health issue. As you know, the emerging global health issues is not just pandemics, which is now a non-traditional security threat. And all the WHO has been warning about the emerging and the re-emerging infectious diseases. The old infectious diseases like HIV, TB, malaria are all now making a comeback as the virus or the bacteria start evolving. But in the last decade, WHO had been focusing more on antimicrobial and antibiotic drug resistance. So as you had new drugs coming on board and new kinds of resistance have built up among the virus and bacteria and becoming super bacteria and super viruses. But of course, viruses mutate much faster. So the implications for public policy will be very, very grave, you know, as you have a new cross-border health, whether it is travel or trade and trans-border risks that is transmitted from one part of the world to another part. And of course, this whole issue can be related to the much larger issue of climate change and our global warming effects on pollution, on environmental degradation effects, on water supply, on food security, and of course, one of them is global health issues as well. And so along the way, we have all these disaster responses and humanitarian assistance programs as we tackle some of these new challenges and becoming more and more frequent. So much so that actually they're taking up a lot of our resources and our time. and it will not it will have some indirect effect on our social lifestyle and our chronic and ongoing chronic diseases as our population move on to new patterns of disease. Every now and then we will have all these new emerging infectious diseases that will plague us. But of course, we have also the other health related issues, threats of bioterrorism, international aid and development assistance, some of the trade issues regarding health products, WTO negotiations, the medical tourism, the migrant health issues, migrant health, even among our health workers. Then we have all those IP rights issues related to trade, and most of them are focused on the new pharmaceuticals and the healthcare innovations and drugs and so on. So biotechnology too, and the pace in which is creating a lot more disparities between the richer countries, those that are involved in the innovations and the research, and trying to get some intellectual property rights and some profits from it, versus the increasing gaps between the poor and the rich, which have also now led to other issues, health-related issues like sales of organs, human trafficking, questions of ethics and morality, and etc. etc. Right, so let's focus on the topic, which is the socioeconomic impact of this current pandemic. You can actually look at it from many different aspects, and the UN, in fact, just as the COVID pandemic affected us, has put up a framework for socioeconomic responses. So you can zoom in on the poverty to look at income distribution between the rich and the poor, and the gaps are going to widen. And certain vulnerable groups like gender equality between the different sexes, the traditional caregivers who are women, and homemakers who are also women, versus the men who are going to be high income earners. And now it's going to affect your employment and your trade as well. So everybody is being affected, but there's a lot more inequalities and disparities between rich and poor. In terms of education too, has also disrupted education. So you can also look at the differences between those who are attending schools and different age groups. Or you can look at social protection, those who are affected by it or receiving some form of welfare or assistance from the state. And they will be grossly affected when their social security is affected as a result of disruption in work or shortfalls in the government trying to give the payout. You can also look at certain vulnerable groups like disabled people and how they're going to be able to fare. And you get reports from all over the world that they are going to be affected very severely. And also the poor in the slums, because they live in crowded conditions, poor housing, poor sanitation, they are more vulnerable and prone to any form of infections than the rich who are socially distanced and so on. So SARIC has just, and the colleagues have just published something that is going to affect our work, the implications in terms of our job, our workplaces, and so on. And I strongly recommend that we look at it. What about the migrant workers or foreign workers who are sending remittances back to their home, or even within the same country, those in the cities who are now affected by the work and the income, and therefore would have no money to send back to the loved ones at home. Trade issues, trade is at a standstill, grossly affected. So without the economy humming again, and without us solving this big problem, trade cannot come through. So you can actually do a lot of economic studies on the prices that have been affected, and also the insecurity that has been posed now, where food is concerned, and some of the basic necessities when supply chains are all disrupted. So of course, people who are involved in the booming tourism before the pandemic, and who are affected by business, travel, and so on, this has all been disrupted by the pandemic. The recent issues of the economists estimated that the prices in America alone led by about 4.3% to the month of August. And in the Eurozone, inflation has hit about 3.4%, the highest rate in over a decade. But it's a moot point what will happen when the pandemic ends. Will we reach a period of stagflation with weak growth and very high inflation, which is going to be reminiscent of the 70s with some of the disruption? Or as we go into history, when we look at the effects of pandemics, we will actually see that like a jack-in-box effect, the economy is going to bounce back, in a V-shaped recovery. So it is a moot point because a recent study of 70 economists predicted that it will be like the historical trends. But the international bodies like World Bank and IMF have predicted that you're going to end up with stagflation. So it's a moot point what it will turn out to be. But when SARS occurred years ago, I had devised a model to calculate the cost. But it was easier to do then because we imputed or we estimated the cost because it was a very short-term effect. It was like over in 6 months. So for that period, we can actually estimate or impute all the costs. And basically, it's going to be very difficult for this pandemic because we have so many variants and it's never ending, the wave after wave. So when it's going to end, we don't know, we can't predict it, right? So how can we predict the long-term costs, whether it's direct or indirect? Now, using this model, we can say that the direct costs of medical care and public health care can be estimated, right, from the supply side, how much the government is spending and how much is going to be spent by the average household or the population in terms of care related to the pandemic. But in terms of indirect costs, that is the productive losses because of this public health intervention or the medical care. I think what will be more difficult to estimate will be the indirect costs to the economy. The total losses in terms of industrial productivity because of the standstills, because of the lockdowns, a lot of trade is disrupted. A lot of businesses are going bankrupt, and it is still ongoing. It's still ongoing because the pandemic has not ended yet. So we can be so sure that the indirect costs are going to be greater than the direct costs. That even as we get more and more medical knowledge about the disease and to try to prevent it or to treat it better, those costs can be ascertained. But I think those other causes of other costs related to the disease, the multiply effects, the mutating variants, and even the sequelae of long COVID, because now for those who are affected and who recover, you can have the potential cost later on in life of a long COVID, and that is still being studied. What about all the other externalities and repercussions, like which is affected by your time, it's not acute within a fixed time. Now it's going to be chronic too, and there may be other mitigating circumstances and so on. And also some other kind of spillover effects. We don't know yet. We're still studying it. But what we do know is that this pandemic appears to be the worst since the Great Depression of the late 20s and the 1930s. And the impact will be more inequitable. It will affect the poor and the low-income developing countries more severely. So we do know that at the population as well as the individual level, there will be a very significant negative impact, which is still being counted. And it is because of the time lag. We don't know until the pandemic stops. And so the long-term effects will have to depend on factors like the responsiveness and effects of any kind of stimulus programs or rescue packages on the government in terms of post-pandemic recovery, and also inventions and innovations on the preventive and the treatment side. But maybe we can take a leave from past pandemics. What are the lessons of past pandemics? Now, if you go back into the most severe pandemic of the Spanish flu, it was so named Spanish flu, but actually it's more American, European disease. It was invented, it was said, it was invented in the trenches of the world wars, and say among the troop ships who were all crowded in the trenches, as well as the warships and the army camps, and it sort of spread like wildfire. But travel and technology was much slower in those days. So while it took like 1 or 2 years of journey to move around, now with the airlines, it just takes a couple of hours or a few days, you know, and you will get around. So the technology has changed, the speed of spread and infection has also changed. So we don't know whether we can use history. But if you look at the same virus that caused flu, you know, and now it is causing COVID, and the different variants that come about it. Now, it is estimated that by the time the pandemic ends, we're going to end up with about 4.5 million deaths. Sorry. What is reported up to now is 4.5 million deaths, but by the time the pandemic is over, plus the unreported one, the estimated one, we think that it's going to be 15 to 18 million deaths. So which is still substantially less than the Spanish flu. But remember that medical technology has advanced quite a lot this time, but so is the technology in terms of travel and other areas too. So we can't use history as a guide. This was the same question that was posed to me about a month ago. When will the pandemic end? Nobody knows, you know. So if you look at history, history says 2 years, but now the conditions are very different. So we can't say. What if there's a new variant, you know, that comes along, which is even more deadly? But what we do know from the we need to mobilize global resources, that we need experts in all the different disciplines related to pandemic control. We need international representation from many diverse organizations and different nationalities, because it's a worldwide disease. And we need very rapid communications and sharing of information, real time, online, between those people who get the diseases, report the diseases, and once it's confirmed, to straight away relay to other countries and other sources via WHO or their ministries of health. And that is probably one of the determining factor on the element of how accurate, how reliable are those data, because we are now relying on public agency like WHO or our governments to do this work. The usual response, which has been agreed by governments when we are dealing with emerging infectious diseases, is that they must give a global alert, very timely reporting. They must define the case well, so as to separate the normal diseases, normal flu, from new novel diseases, so that the measures for surveillance and the follow-up and the assessment will be accurate, because you have got very timely updates and information sharing, so that the control measures, you know, whether it is quarantine or whether it is a vaccine certification and so on, can be timely as well and can be effective. So what powers that WHO have, you know, because it's very much like a voluntary organization, depending on the membership of the different countries. So the world has not given WHO all the mandates, except basically WHO has got this authority to recommend or not recommend essential travel. And then it is up to governments to legislate whether they're going to ban the travel or not ban the travel. So WHO is just representative or advocacy. But within WHO, you have a WHO Global Outbreak Alert and Response Network, or GOM, which was set up after the last big SARS pandemic. The current chairman of GOM is an Australian professor, Dale Fisher, who happens to be now in Singapore. Is in Singapore now. So you'll be surprised, or rather you won't be surprised, that the WHO recommendations is just a few months after the Singapore government's report. When the Singapore government, because we have mechanisms to be quite up to date, it's a small country and it's very responsive. So WHO takes its cue from small, well-regulated states like Singapore. But basically, the GOM is this technical collaboration among all the experts and institutions. And it's a real-time mapping device and the intelligence network to recommend and advise WHO on some of the situation regarding diseases, especially infectious diseases, so that WHO can come up with some recommendations. So you need scientific collaboration. It's no point making use of all the new policies when it's not related. So you need good evidence. You need online and very practical experience, so that the context is very important. What happens in one country must be relevant to another country, so that from an international basis, WHO can make all those solid recommendations based on the diagnosis, the effectiveness of the vaccines, and the treatment protocols. So the standard public health measures that in tackling infectious diseases are usually, the principles are to detect and then to isolate them and then control for public health measures for control of infectious diseases. And the step-by-step is you have to have good screening tests, then you have to have systems of notification, of surveillance, and then to isolate them, you need quarantine periods, depending on what you know about the disease itself and the incubation of the virus or the bacteria. So the quarantine period is usually a period as a safe period that covers any infection control. So from about 2 to 3 weeks now, we are a bit more certain that most countries now have narrowed it down to 10 days, 10 days upon the PCR test that confirms that you have a positive carrier. So they allow a 10 days clearance now. But if you're not sure, the initial period is about 2 to 3 weeks. And then all the contact tracing, which is very tedious and very manual, you have to find out the infected patient, where he has been, who has he or she has been in contact with. And then the traditional public health method is to intervene by cutting out the route of transmission, by active contact tracing, and therefore to also isolate these people. But increasingly, it's being very, very difficult now. As you can see, it's also very costly, to be able to do the contact tracing. So once at the beginning, you can nip the problem in the bud by doing very active contact tracing. But once it goes out of hand, it goes in the community and it gets lost, it's hopeless in the situation. You just have to wait for the wave to carry through the whole process, because the contact tracing will be so costly and so tedious, it's actually meaningless. So that's the traditional way in which we control outbreaks. So when outbreaks takes place, we don't want it to spread. But in the case of COVID-19, it has already gone beyond our control. Our government has gone beyond the local outbreaks into a worldwide pandemic. We are hoping that vaccines or some form of prevention and also treatment in terms of drugs will also take place. But as you know, vaccines and drug treatment is not 100%. So you still need to support it with good education and good enforcement through the law. So the basic public health education regarding safe distancing, use of personal protective equipment like masks, and then avoid crowdedness, avoid places that are not well ventilated, which makes a lot of common sense. These are all the common public health measures. But to the extent to which they have been implemented will require a system of law and enforcement and many countries have fallen short out of this, because of poor governance or laxity. So you need a whole of government approach against the pandemics. And so when epidemic takes place in a particular country, usually a government would have an interministerial task force, and it's not just the Ministry of Health to focus on communicable diseases, which you may bring in the experts for infectious diseases, but you also have to bring in the people to do the policing and the security, because they have a lot of implications on the economy and on trade and so on. So you have to bring in representatives from all these different ministries. Now, in the case of Singapore, a country that I know best, basically we have now almost daily communications between interministerial task force consisting of the main ministries like health, finance, and security. At least 3 ministries will have to come together to continually brief and to make announcements that will affect the public. So you need a lot of trust between the public and the government, and within the government itself, you need a lot of trust between the different departments. So building trust and community support is very, very important, and you have to show it in the form that the government cares for their workers, and the people also care for the people who care for those patients. And we don't just demand our rights, and we demand our that the public servants give the services, because there are also risks that are posed upon these healthcare workers. So why should they care for us? Because the vaccination rate is actually quite high now. It's about 15% among public health workers ever since COVID started, 15%. And we don't want healthcare systems to be overwhelmed by all these unnecessary fears and mild cases, so that the more serious cases will not be taken care of, because the ones that require the oxygens and the ICU care in the hospitals, they need to be isolated. Otherwise, they will also spread and start affecting those with the other chronic conditions. So we have to communicate. It's not just a question about legislation and enforcement, but you have to communicate well, especially with all these anti-vaxxers and the fake news that's going on. You have to have very accurate, scientific, state-of-the-art news. Otherwise, the fake news is going to be even more contagious than the pandemic itself. Now, this was a picture that was taken. As you can see, the variation, the variety of responses. Some of these masks are useless. They don't work as well. They are more decorative than all. And then some are overkill. Some of them are too much for it. So you need to have the right information so that people are protected. Now, we learned a few lessons from SARS, because SARS affected mostly the East Asian countries. So out of SARS, we knew that we had to standardize the screening for travelers from one country to another country. We have to have the same standards for travelers moving from one country to the other. And we need to share those information. Those countries that hold back the information, they're going to start affecting other countries in a very selfish manner. As a result of SARS, where about four ministers of health lost their jobs, starting from China, Hong Kong, Taiwan, and even I think it's Korea. 4 ministers have lost their head, but in Singapore, fortunately, unfortunately, we rotated the responsibilities. So instead of just the Minister of Health giving the briefing, we spread the risk as well as spread the task by having an interministerial task force. But the good thing that came out from regional approach is to create a center for disease control. So out of SARS, we now have got a ASEAN regional research center who just focus on communicable disease division. But SARS came and went very fast. So all we have left now is the last time I checked was about a 6-man communicable disease division that's set up in ASEAN Secretariat in Jakarta, but it sort of like straddles the two WHO regions of Wipro in Manila and Delhi, Sero in Delhi. But one of the few lessons that we learned from control infections is that we need good governance. Right? The first thing is good governance. We need openness and transparency, especially in reporting diseases and to give accurate information and up-to-date information that will affect other people. And then we need to overcome public fears. We need to give the right information and not to instill stampedes and you have this, where suddenly all the runs on the supermarkets and on the banks, for example, or whole villages, say in China, were barricaded, and the stigmatization that goes on against people who were fearful, when the public is fearful of them carrying the disease. We need good governance where you have swift and very decisive action. And from the SARS experience, we realized that so many ministers lost their head, and especially very arrogant. This is my friend, this former ex-minister who is now a professor in public health in the Chinese University. He was then the secretary for health in Hong Kong. He was denying some of this, and he was actually shutting up some of the journalists for raising this issue that it was an unknown disease that came from Guangdong that started affecting Hong Kong. Of course, he denied it as a specialist, but in retrospect, now he was wrong. So the same thing when we look at COVID-19, the systems that had prior experience with SARS, like China, Hong Kong, Taiwan, Korea, Singapore, mounted early responses that seemed to be very good, but because the whole world did nothing or had very late responses, like the emphasis on human rights, wrong policies like the herd immunity policy, which is to do nothing and let the population have it, be infected. Because of the slow responses of other countries, now we have all the variants that is now coming back and starting to create all the subsequent waves that is also affecting those early responses that seem to have worked rather well. We also need good governance in terms of international cooperations. Now, for example, I don't know whether you're aware that before COVID started becoming so intensive, the small countries came together through the United Nations and they formed a COVAX facility where they all agreed that 20% of the vaccines was going to be guaranteed for the essential healthcare workers and the most vulnerable, meaning that the old people who have got multiple conditions. And that was their way to guarantee equity. Now, this was co-chaired by Singapore and by Switzerland. These are small, rich countries that wanted equity for the whole world as well. We also have international cooperations like between countries, richer countries who have hoarded some of this supplies, essential supplies. But now they are sitting on top of all these vaccines and other countries need it. So now we have got mutual exchanges of vaccines. Like for example, between Singapore and Australia, we have this possible exchange depending on where the needs are. We also have, along with COVID, understanding between governments versus big pharma. The big pharma, of course, in places like the US, are against committing themselves because they want to make a profit from the intellectual properties. They thought they've invested so much in the R&D and so on. So now is a good time for them to reap the profits. But once it has been declared an international public good or is an international urgency, governments sometimes apply rules of foreign diplomacy, and they may want to do it to get goodwill or to have some preferential treatment. And this is actually morally not correct. And some countries, some smaller countries like Israel have prepared themselves well to have strategies with Pfizer to negotiate that if we give all the data and we humanize the whole country, would Pfizer give them a discounted rate? Okay, we don't know what kind of preferences they have. But what I do know from Singapore, we also had a similar strategy with Pfizer, because some of our advanced researchers who have done the mRNA, have replicated the technology and so on, were quite certain that Pfizer had the modern technology that was appropriate. And therefore, we were able to negotiate with Pfizer at an unknown price that if Singapore adopts Pfizer as the vaccine, will we also get a discounted price? Because it has a lot of implications for the region as well in terms of pricing. So whether we like it or not, we then realize that some richer countries would probably have more money, whether it is to afford vaccines or to the more effective vaccines or drugs and so on. But if the pandemic goes on for a long time, you end up with a situation where everybody gets affected. So it's a question of lives versus livelihood. So even if you have vaccines that are more effective than others, after a while, not all vaccines are 100%. So you will have continuous waves of variants as well, and those original vaccines that were based on the prototypes, the earlier versions, may not be as useful. So we have a question now. Where do countries now balance in terms of policy the life versus the livelihood? If the pandemic goes on and on and on, when will you decide which is more important, your economy versus the lives? Therefore, you have to do your sums. And some people are very upset when lives are, in a way, we are calculating the cost effectiveness based on how much sacrifices or cost in terms of human lives. Some people are very, very upset about this. But eventually, governments have to do this hard job of deciding when is the time to lock down and when is the time to announce the freeing up of the economy. But we know that when the pandemic, if the pandemic is raging, then all this cripple, the economy will be crippled, where you have lockdowns of factories, work sites, and services and industries, the trade and the travel bans, etc. These are all going to add on to the transaction cost. And right now, we already know that the tourism industry, the airlines, and the travelers are all affected very seriously. And so we did a major literature review to see, okay, what is the prolonged effects of diseases and pandemics on financial crisis and recessions. And this is what we actually saw, the link between health and the economy. I don't have very much time. I'm just going to run through very quickly, but to tell you what is the possible things you can do in this pandemic. For example, in the past, Brandon has looked at the increase in mortality or morbidity in terms of measurable health indicators. Mental health issues have been correlated with prolonged recession. Malnutrition has also been shown. Immunization levels have also dropped, which has led to the rise in spread of infectious diseases, like in the old USSR, and then polyomic resurgence in places like Indonesia. And of course, there's a lot of health related issues that are linked to jobs and employment, like insurance and the protection. Okay, this was an event that was organized at Lee Kuan Yew School a few years ago, when we had the SARS and the regional economic crisis, and we organized a UNICEF conference, and someone presented a model to show the link between the economy and health, and I thought this was worthwhile to share with you, that because of the economic crisis, following a pandemic, then it will also have some effects in terms of the responses of the coping strategies of the public. They will either cut down the use of services or they change their priorities, and therefore they will need to adapt to the the crisis, and in the longer term, it will start affecting their own health or their own mortality. So I thought this was a model that we could use. At the same time, when we look at the impact on certain vulnerable groups, the literature also says that the vulnerable ones will be the ethnic minorities, the poor, single mothers with children, elderly and disabled. In other words, the people who are poorer and have less income or are much more dependent on the others. Foreign workers, especially in Singapore, and their dependent families in their home countries, and some of the older and lesser skilled ones who will be first to be retrenched, or not to be rehired in the new economy. And then the impact on utilization of healthcare, we also saw in the literature that the East Asian financial crisis was well documented, where people had a reduction of use of health services. And especially just at a time when you need to use the services more because of the pandemic, the government doesn't have the money to finance it. So the government will be in debts or have to borrow a lot of money to keep the public services going. So some people and some governments, in fact, delay the caregiving process, and they will resort to other alternatives, which again will have some consequences. So the time lags as well as the sequelae in terms of coping with the disease are important things to study as well. What about the impact on mental health? And I think now this is of grave concern, because it's not just the effects on the physical health, which are more tangible. I think the longer term ones in terms of substance abuse, alcoholism, domestic violence, the divorce and the family breakups, the longer term mental disorders, the suicides, attempted suicides. These have all been documented. For example, in the last financial crisis and as well as the last SARS, we have actually done some of these studies. In Japan, Korea, and Hong Kong, 10,000 more suicides happened in the last financial crisis. Now, what about the post-pandemic policy options now that we have? I will just end up by saying that because of our experience with similar pandemics, government would have a critical role, to provide the safety nets. We can actually plan for some of these possibilities. And government will have to provide, is expected to provide a safety net and social protection for the most vulnerable, so that their access will not be disrupted. And we have to then re-examine our priorities in terms of where you want to allocate your resources, the public resources, and we need to diversify the financing and to have some new strategies of financing. So the opportunities are there for us to make the reforms and to prepare for the next major crisis. And WHO estimated that the rate of a new novel disease will be at least once a year. So which will be the next major pandemic that's going to start affecting it. So, and also the mental health issues, that's going to start affecting people from a social perspective. So I've written about this after the SARS crisis. There's an editorial where we say government will have to strengthen some of the mental health services in anticipation of the next pandemics. So all the investments in prevention, in early detection, treatment of diseases will be good public policy. And I have some estimates, some economic estimates to look at the returns on the cost of investments in this area. So what about other psychosocial needs that will also start affecting your security, to have the peace of mind, a sense of security, to have affordability and old age security, and also regional security for the region. So the lessons we learned of SARS as well as the beginning of COVID is that we need to build a good public health infrastructure to involve all the key stakeholders and to mobilize the community into providing this infrastructure. We need to also have very effective business communications that will affect not only those people who are affected, but who are going to determine whether the pandemic can be arrested. So to prepare for the next pandemic, to have the responses, government and the responsible bodies, such as to do the investments in research, to have enhanced international cooperations between all these different parties. So my conclusion is, from this last paper I presented about 6 years ago, should we then control infectious diseases to securitize it? It's not securitize it from the traditional sense, but as a non-traditional security element for better global governance. So the lessons we learned was that we need to move away from policy into action. So coming from SARS prompted the reaction, it provided catalyst for the politicians to come together in our region, Southeast Asia, ASEAN ministers. So because of SARS, it led to a very regular series of meetings between the health ministers. And so when COVID came along, we had the infrastructure. And so it evolved and became talking and a policy comparisons that was made between countries in our part of the world regarding infectious diseases and what people are going to do. So in the remaining minutes, I just very quickly just go into what we did in Singapore earlier on.
Ayong, you're a little bit over time, and we would like to keep some time for questions.
So maybe this part I'll just skip over, and then we'll just go on to the conclusions. Right? So if you're going to ask me some questions about how we manage it in Singapore in terms of our policies, maybe I'll save that for the question time. And then in terms of the strategies for savings, but I'll just end with the way forward is to have very sustainable joint action and cooperation. And we need to integrate the region under existing collaborative frameworks, not just the trade agreements, but also some of this public health collaboration as well. So the public-private participation of government, industry, and the voluntary organization with international works must be enhanced and strengthened, so that the training, the education, the research can continue to give us greater cooperation and consensus and the common action, so that regional solidarity can be maintained to tackle any common threat. Thank you very much.
Thank you, Kai Hong. The floor is open for questions. We have some 10-12 minutes for Q&A, where we can explore some of the aspects that were not covered in sufficient depth.
Maybe I will start off with the first question. And what did we do in Singapore? Maybe that'll give me time to go over 3 or 4 of the slides here. Okay, I think one of the things that
I think. Sorry, go ahead.
Okay, sorry, I'm trying to go back to the slide, the previous slide. That okay. Okay, I think this one. If there's going to be any lessons, it is. I think these two slides will tell you. Essentially, WHO, the regional office, got hold of the Singapore case study and say that maybe we can perhaps share it with other people. If you notice that in the early days when SARS first appeared, it came mainly from China and the overseas visitors. So we controlled that, But then we were blindsided by something that happened within the community, and it was our foreign workers, because the vulnerable groups that were less affected, that were more affected, were not part of the healthcare system. They didn't have the same educational or income status as the regular Singaporeans. So they began the second wave, So we had to then make an enlightened policy to also offer vaccines, what we are offering the Singaporeans, to also give to the foreign workers. So we were able to address this. As you can see, this was the early wave until the variants came along. When the variants came along, then the early contact tracing and the early vigilance was not maintained. So the strategy then was to be very scientific about it. You know, the so-called circuit breaker policy. I don't know whether you have heard of it, but the Australians adopted this because our previous health minister was an electrical engineer, and so he brought in his electrical analogy that you need to be very scientific. So, which means that the information you collect must be very accurate, like how many people get infected, how many people die. You know, it must be on a daily basis so that you can make all the responsive policies. But from a policy point of view, it's very confusing to the people. You know, one day is this, another day is that. You know, so you have to be very consistent. So with an educated policy, with an educated population, a smaller place like Singapore can do it in a scientific manner. But for a larger country with very wide ranges of educational levels, you may have a problem. But one of the things that I probably want to think that will work very well is the appointment of an expert committee. I think that's very, very critical, because if you don't have that, all the flag will be taken by the Prime Minister or the Health Minister. So what we did in the early days was to appoint an expert committee. All the best experts on infectious diseases, on health, were all put on it. So the public would have confidence and have trust in all these experts instead of politicians. No? So the politicians come to give the daily reports and all that. But the expert committee will have to make critical decision of the use of vaccines, what vaccines to use, and when is it going to relax and to enforce certain things. You know. Also, we had some early purchase orders. Some of our people will be substituting and doing the mRNA technology, make sure that it is safe, right? To make sure that Pfizer and Moderna vaccines were the state of the art, because we can do it ourselves. Then we can use it as a bargaining chip. So when we started negotiating with Pfizer, we said, look, if you don't give it at this low price, we're going to manufacture ourselves. You know, that's what we did for our water with Malaysia, and that's what in the WTO agreements for HIV, the big companies have to lower the prices by almost 2/3 because the countries like Thailand and India and South Africa and Brazil, you know, we're saying that it's a very simple thing to mix the cocktails. So I think we should do this. We should actually bargain with all the big farmers and then to get a better price. Otherwise, we'll be held to ransom and the monopolies will come in. And then you have to have very clear-cut policies regarding your vaccines and also subsidy. Now in Singapore, because we weren't very sure, the expert committee were very sure about mRNA, but so 65% of the population were vaccinated, right, and subsidized. But for the 25% who still preferred the old unattenuated vaccine, the Sinovac, the one made in China, we could not subsidize them because there was no information, there was no accurate feedback about whether it works or not. So until such time they were able to give us an explanation why the earlier trials in Indonesia, in South America were so variable, until such time they were able to give us, we could not turn it into a national vaccine. So the subsidies was not there. And it mainly affected the old people who were still very pro-China, you know, the older generation, who didn't want to be vaccinated against the new technology, and therefore contributed to the anti-vaccine movement and had preference, like cultural preferences for the old vaccines. So you have to then educate people. You have to bring them on board about the technology as well. You know. Yeah. So I think this is probably something that we can probably share, and it will be applicable in any policy situation.
Sorry, Kai Hong, I have a very quick question. So while the other participants think about what they want to ask you, because I think they're a little bit shy at the moment. Several governments have started providing a third vaccination to elderly segments of the population, and eventually the whole population will receive a third shot. In Italy, the members of our COVID committee of experts have said that there's not such a thing as having too many antibodies, and so it would be a good idea to get as many shots as possible. And they were even suggesting that since the efficacy of the vaccine after 6 months starts declining, we should be undergoing vaccination every 4 or 5 months. Do you think that's a viable option?
You see, the trouble with all these new novel diseases and vaccines is that it's not been properly evaluated. Unlike other vaccines, which takes about 5 years at least, for proper evaluation, and then they rely on volunteers. For this one, because of the emergency nature, WHO has given emergency approval. So any vaccine that came along and has able to show some cause, based on the preliminary trials. Now, some of those are not peer-reviewed, as you know, but WHO sort of make a guesstimate to approve it. But those questions you asked about mixing the vaccines, about the age ranges and so on, are being trialed right now. And now they are, even in Singapore, we are asking for volunteers, like for the below 12 years old, below 12 years should be vaccinated. And we are asking for volunteers. So that's being trialed as part and parcel of this. But of course, the big farmers who have a vested interest to sell will say that it's safe, But we don't know, because the anti-vaccine and even very educated people are saying that, hey, wait, what about the long-term repercussions? Our child are still developing right now. Because if you vaccinate them, what happens if you have all those side effects? And some of the side effects are true. I mean, but from a statistical point of view, they are very, very small. The risk is very small, but the side effects are still there. So all you need is just one case, and then it get blown up by the gutter press, and then it becomes very bad policy for any health authority to try to push that. That was the situation with AstraZeneca in the UK, but now it is shown that the evidence is showing that the AstraZeneca is actually a very good booster, They said it's probably one of the most effective. So for those who are vaccinated by Pfizer like us, they are saying that the booster effect of Moderna is even better than 3 courses of Pfizer. And the AstraZeneca one is even better. So we don't know. So until the evidence are all in, and then we can make a very objective assessment of all the comparative experiences, all the different, this is in lieu of a proper evaluation. It's actually being taken place live right now. Yeah.
Thank you so much, Kai Hong. Any questions from the audience?
Well, maybe I can prompt another one, because this is it's a very specific thing that requires a lot of evidence, a lot of knowledge first, before you can get into the public policy implications. So then you ask, what can we do beforehand? I said there's a lot you can do. If you look at what this the GSPP has been doing, last year at the height of the COVID situation, we had wanted to bring an expert committee, and we had a panel, and we thought by that time COVID pandemic would have ended. And so we had a committee at the last GSPP conference, where Colin and Byron from the medical faculty had participated in the panel, and I brought along the 2 professors from NUS, and we thought that at first COVID would be over. But even then, it was just evaluating the initial stages of it all, because right now you can see the variants, there are more and more waves coming along. Also last year, we had a research seminar. You remember Simeon gave one to assess the policies, lockdown policies between Kazakhstan and Kyrgyzstan last year. And of course, I had a chance to look at the paper as well. It was actually quite well, the conclusions were correct, because if you compare Kazakhstan and Kyrgyzstan, Kazakhstan was very severe, but the results were the same. So what's the point of having such a severe reaction, in terms of disrupting people's life and so on, when just across the border in Kyrgyzstan, it was more lax, So you have to have this kind of public policy comparisons, and the comparative research as well as the historical research will add some value to our understanding. But I would say that going forward, the current joint research now that has been committed, that has been going to pass in healthcare, myself, a professor of NUS, and then Dina, we have published a very short piece on something you have done here in Astana a few years ago after the Declaration on Primary Healthcare. And then a few other groups, and just a few hours before this seminar, CERIT has also published a paper together with NUS colleagues at LKY School on work processes that is affected by the COVID pandemic. And then for a coming seminar, Iftaka and myself will be presenting a paper to look at the historical development of the system and how it's going to respond to COVID. Also, for our PhD research going forward, for the first time, I have a public health person, with the experience in Solid, and she's interested in doing extension of primary health care and its impact on the health, whether it's in Kazakhstan or the world. But I think these are potential areas in which the school, from a public policy perspective, can get into an area where health can plug in, and also public policy can also start affecting your health research.
Thank you, Kai Hong. I'm afraid our time for this evening is up. So thank you for a very, very rich and very detailed presentation that I think deserved at least 2 presentations, because if I'm not mistaken, you have 56 slides. And thanks to all the participants for coming and join us and to attend this presentation that provided a wealth of information about an issue that has radically changed our lives in the past couple of years, and that is not over yet. So thank you so much, Kai Hong. Thank you, everybody. And we'll meet again soon here in GSPP webinars. Thank you so much. Bye-bye.
Thank you. Thank you. Thank you.
Thank you.
Bye-bye.
Thank you.
Kai Hong, I'll see you in the atrium.
I'm in my office right now. So where can I?
Atrium, 5 minutes.
Okay. Okay, I'll be here. All right, thank you.
All right.